I would welcome you all to the August 13th meeting of the Board of Directors of Washington Township. If you'd all, I invite you all to stand and join me in the pledge. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Christine, if you'd take the roll for us, please.
Stewart.
Present.
Director Nicholson.
Present.
Present. Director Easton.
Present.
Thank you. Thank you. Our first item on the agenda will be an education session. Nancy, if you could introduce that for us.
Yes, I would be happy to do so. Tonight we have both Dr. Carmen Akawili and Dr. Daniel Sweeney here. Dr. Akawili is the medical director of our intensivist program in ICU, and Dr. Daniel Sweeney is the assistant medical director. He'll be speaking first, and I'd like to give you a little bit about his background. He graduated from the College of Holy Cross with a Bachelor of Arts in History. After serving as a volunteer school teacher in Mississippi and Texas, he earned a master's degree in microbiology at the University of Texas, El Paso, and later completed medical school at the University of Texas Southwestern Medical School in Dallas. He's currently enrolled in the Master's of Epidemiology and Clinical Research program at Stanford University. He completed his residency in internal medicine at Albert Einstein College of Medicine, Jacobi Medical Center in the Bronx, New York. He subsequently completed fellowships in infectious disease at Johns Hopkins School of Medicine and critical care medicine at the National Institutes of Health. He has published more than 10 journal articles and book chapters. He's board certified in internal medicine, infectious disease, critical care medicine, and neurocritical care. He's also active in antibiotic stewardship and bedside ultrasound teaching for both physicians and staff, and continues to be active in medical societies at the regional and national levels. He's a volunteer instructor at San Francisco General. He teaches at the yearly Society of Critical Care Ultrasound course, and he is a member of a panel of physicians who are revising the American Thoracic Society Infectious Disease Society of America guidelines for nosocomial pneumonia. I would let the board know also this evening Dr. Sweeney is on call. Shortly after he completes his remarks, he'll be leaving.
Okay, I'd like to thank you for this opportunity to describe to you an ongoing initiative in our department, and this initiative is entitled Patient and Family-Centered Critical Care. So what is this patient and family-centered critical care? So if I could leave you with one nutshell or sort of one take-home message, what we're proposing here is basically a new paradigm. In the past, it's always been the patient. There's been two models: the autonomy model, where the patient has control over all of their care, they make all of their own decisions, and the fallout from that has often been in the past that the families and the patients have been overwhelmed with the information, somewhat unprepared to sift through that information, and the end result is sort of an unsatisfactory experience. The exact opposite of that is this paternalistic model in which the doctor makes all the decisions and the family is completely and the patient is completely left out of the loop, and that's not ideal either. What we're really proposing with this initiative is an effort to sort of make a hybrid model in which basically the patient and the doctors and the whole care team sort of work together as a team to take care of the patient and guide the patient's decisions. So it's sort of interesting that we're discussing this in 2014. This was actually an idea that has been sort of championed at this hospital by Nancy Farber, and the ball has been carried further by Carmen Akawili. Actually, even before the Society of Critical Care Medicine came out with their guidelines on this topic in 2007. One of the key components to patient and family-centered critical care, and you're going to hear this over and over again, is the importance on communication. And one of the mnemonics that's out there in the literature, and we've tried to adopt ourselves, is this mnemonic of value, where when you approach a family, you remember to value the family's statements, acknowledge their emotions, listen to the family, understand the patient, and ultimately elicit questions from the family. So in order to achieve this, you have to start with a committee. Isn't it always that way? And in 2008, such a committee was put together. Monthly meetings were established, and I need to address and give all the credit to the standing members, Dr. Akawili, Erna Lasabal, Cindy Wojin, Rudy Teodosio, and I'd be remiss if I didn't mention Father Jeff, who was also one of the founding members. In addition to the standing members, there's an ad hoc committee that you see listed there. So the core concepts of this family and patient-centered care, again, the word communication and collaboration. The idea is that you have a multidisciplinary team that collaborates with the family and the patient to keep them informed throughout the process, clear explanations, describe for them what their care is like or will be like, and make sure we provide communication options for our non-English speaking patients and family. Dignity and respect is another core concept. We provide support for patients and caregivers according to their individual needs. And participation. We feel like this sort of initiative has the care team working harder, but we also expect more from the patient and the family in terms of encouraging them to be actively involved in decision-making and driving their choice of care. So the fallout, the benefits of all this is that with a patient family-centered approach, you provide right care at the right time. It's been shown to improve, in particular, quality and satisfaction of care. It's a family-centered approach, encourages a collaborative approach to care, and it promotes honest, and here's that word again, consistent communication. And again, patient-centered care should, in theory at least, promote cost efficiency. I'm showing you here sort of the big picture of the accomplishments or the key components to carrying out this initiative, and allow me to describe some of these in detail. The first component is this Guide to Critical Care Services many of you have in front of you. This was a publication that was created in 2013, and all of our patients received this or their families received this on admission to the ICU. And it's essentially a quick reference for the families. It provides an overview of the care that we provide. It also goes on to even provide information about post-discharge and transfer care. On this slide, I'm simply just showing you, if you don't have the handout in front of you, a quick snapshot of what the inside of this booklet looks like. Oftentimes, or not oftentimes, right in that packet, we include this questionnaire entitled Getting to Know Me. And the idea behind this is to sort of personalize the patient. It's a chance for the family or the patient to describe who they are. And this results in developing patient-caregiver relationships there on a more personal level. And again, if you don't have it in front of you, that's a screenshot of what it looks like. Another very important component of this is patient-family conferences. And here on this slide, I describe them as occurring on a weekly basis. The truth of the matter is, and anybody who's been in our ICU knows, that these occur much more frequently, if not on a daily basis. The newest component of this initiative is the Critical Care Diary, which is just as it sounds. It's essentially something that's popped up in the literature over about the last 6 or 7 years. And the idea behind this is it gives the patient and the family an opportunity to write down their experiences in the ICU, list sort of the components of their care on a daily basis, gives them a chance to write down questions so that they can ask remember to ask their caregivers what those questions were. And the benefit of this is it's been shown to basically improve communication between the patients and families and the care team. And again, a screenshot of the cover. And then finally, just sort of a quick overview of some of the other patient-centered initiatives. At the top, you see rest periods and quiet time. I find this to be one of the more interesting components because we have to balance this with having flexible visitation hours, because on the one hand, we have patients who generally need just that, a quiet time, but on the other hand, we have to make ourselves available for certain patients in terms of their families and their schedules, and some patients just need family members at the bedside. And so it's a balancing act, and it's something that in particular our charge nurses do a phenomenal job of. I've listed here concierge services, education strategies. We've started placing this butterfly sign outside of doors or on curtains of patients who are receiving end of care or end of life care to remind staff to be quiet and respectful of these patients. A ventilator withdrawal support protocol has been put in place, and there's a follow-up for patients on discharge that's been in place since 2013. This involves both a questionnaire given to the families after they've left the ICU, but also, again, our charge nurses do a great job of going to the floor and seeing how the patients are doing. So as I've mentioned, I think what I've described for you is there's a lot more work that we feel that our team is putting in to the care of the patients, but we're also expecting more from the patients too. And in particular, basically what this model is asking or expecting from the patients is that they speak up, they express their concerns, they don't hesitate to ask questions, they give suggestions. And they also improve potentially improve some of the very measurable outcomes, such as washing your hands and reminding us to wash our hands, providing us with information in terms of, oh, my loved one has an allergy to a particular drug. So this initiative has a lot to do with us, our team, but it's also expecting a lot from the families themselves. Some future initiatives that are being considered include information kiosks, a family comfort care tote bag with overnight supplies, team training, simulation workshops on communication. This is really crucial in terms of really, there's a lot to be learned in terms of how to sort of break down these barriers between communication, or communication barriers between patients, families, and the caregiving team. And of course, funding strategies to continue these initiatives and monitor outcomes. So it's at this point I'm going to pass the baton to my boss, Dr. Akawili, and she's going to describe to you a little bit about Right Care right now.
Dr. Carmen Akawili, Director of the Intensivist Program. She graduated from the University of the Philippines and University of the East Memorial Medical Center. She completed her internal medicine residency at St. Barnabas Hospital in New York City. This is an affiliate of Cornell Medical Center. She did her fellowship in pulmonary and critical care at the University of Southern California, Los Angeles County Hospital. She also worked as a clinical specialist at the LA County Tuberculosis Clinic, as well as an urgent care physician at Claude Hudson Clinic from 1998 to 1991. She is board certified in internal medicine and critical care. She's also a fellow of the American College of Chest Physicians and a member of the Society of Critical Care. She started her private practice in Fremont right after fellowship in 1991. She's also presently co-medical director of the critical care units and the medical director of the Ohlone Respiratory Care Department since 2010.
Good evening, everyone. So I'm here tonight to introduce the Right Care Right Now essay winners. But before that, I just want to let you know that Washington Hospital embraces this innovative concept of Right Care Right Now, which was endorsed by Society of Critical Care in 2005. And what it means is that based on the use of research, best practices, and an integrated team led by the intensivists, we are able to deliver the right care, not only a care, but the right care at the exact right moment to achieve optimal patient outcomes. So I also want to let you know that every May, together with our critical care colleagues throughout the nation, celebrate Critical Care Awareness and Recognition Month. And this is to raise awareness of the things we do in ICU, to recognize our critical care staff, and the valuable work they do. It is about empowering our colleagues in ICU. So you guys have been part of that, our potluck parties, if you remember every May, right? Some of you are smiling. So this May, what we did was engage our multidisciplinary staff to reflect on what this concept means, right care, right now. So we asked them to do some inspirational messages for the critical care society and beyond. Out of 18 entries, out of those inspired writers, we had 3 winners. And the winning entries, of course, we recognized and celebrated them, and also this will be shared with the Society of Critical Care. So here now, we have the 3 Right Care Right Now essay contest winners. The first place winner is Anu Tarur. Please stand up and come over. And he said, right care, right now, providing quality care. We have the second place winner, Ida Lee. Tick-tock, tick-tock. And the third place winner is Heather Heath, Make a Difference. They will all recite to you, share with you all the inspiring words that they have painstakingly written. Come on over, Anu.
Hello. My name is Anu Tharoor. I have been part of this critical care unit for the last 8 years. The idea of this short presentation is to express my views on right care right now as a critical care nurse.
You're doing a great job.
Right care right now, providing quality health care. Blaring sirens, mad dashing around of healthcare workers trying to save lives. Constant beeping of alarms from the monitors. Panic-stricken relatives. This is the perception of a critical care unit for a common man who hasn't set foot in the ICU. But as healthcare professionals, our way of providing care to this person's loved one when he comes to the intensive care unit has gone through a welcome metamorphosis and is still evolving for better. One of the tools we use for this purpose is the Right Care Right Now initiative. What does Right Care Right Now mean? It means providing the best possible quality care to all the patients, all the time, as early as possible, by the right people. How do we ensure right care is provided each time? Following guidelines such as evidence-based practices help us ensure and maintain a standard of care for all the patients with a particular problem without many variations across the board. Following this set standard of care ensures we provide care in a safe, effective, and timely manner. But as professionals, we need to use our clinical assessment and judgment while implementing these guidelines, as the meaning of right care might be different for each individual. That's why I strongly believe, while following a set of guidelines is a must, we need to individualize and be patient-centered. We should always remember the patient-first ethic. Let me give you a few examples. For a 90-year-old man with terminal cancer admitted to the ICU for sepsis, right care might mean spending the last few days of his life with his loved ones, remembering the good life he had, and passing away with dignity. For another person, it might mean fighting to stay alive for himself and his loved ones, knowing it to be a futile effort. Focusing on a set of standards is a must, but in the midst of running a myriad of tests and procedures, we need to also make sure the patient needs are met with ample sensitivity. That's where another aspect of right care comes in, multidisciplinary team approach. How does a multidisciplinary team help us here? This team is comprised of multiple skilled professionals and experts in their respective disciplines. They help us ensure every aspect of patient care is taken into consideration and help us achieve quality patient care. A spiritual care coordinator is as important to the team as an intensivist. Involving patients and their family members in the care program is another priceless aspect. Making them active members of team discussions, making them feel wanted and involved help us achieve valuable patient-centered care. Right care should be safe. Multidisciplinary teams help us ensure the safety by reviewing the patient progress daily and reassessing the plan of care. Another tool that helps us ensure this safety is using electronic documentation, which not only prevents compromise of information as it passes from one individual to another, but also makes it easily available to all persons involved in that patient's care. To summarize, providing quality health care is our ethical obligation. Let us strive towards making this our culture too with this initiative. Thank you.
All right. Good evening, everybody. My name is Ida Lee. I'm an occupational therapist. I have been working at Washington Hospital for about 15 years, and this is my essay. Okay. Tick-tock, tick-tock. A man arrives to the ER with complaining of left-sided weakness. Tick-tock, tick-tock. A woman comes to the ER complaining of chest pain. Tick-tock, tick-tock. A child comes to the ER complaining of abdominal pain. Every day, thousands of people come into the ER with various medical problems. Many of them are treated and sent home. Some are admitted to the hospital for further treatments. And even fewer are admitted to the critical care unit. Our faces are the ones they will first see and remember. This is why what we do is so important. We, as a member of the critical care unit, not only save lives, but we try to return the patients back to their prior level of functioning. Everything we do will have a long-lasting effect on our patients. Every minute in the critical care unit makes a difference of life or death. This is why we need to do it right the first time, and we need to do it right now. One person alone cannot accomplish the task of saving lives. We need to work as a team, providing our expertise on how to provide the appropriate care to our patients. We need to work as a team to provide not only to our patient, but to support each other. After all, we are just human. We will have good days and bad days. It is when we are having bad days that other team members will be there to support us, to make sure that we're providing the most appropriate care. Healthcare workers have great responsibility to provide the best treatment to our patients. In order to provide the right care to our patient, we need to be competent in our field. We need to be continuously updated ourselves with the latest evidence-based studies so that we could offer the most appropriate treatment. We need to take time to listen to our patients and their families regarding their concerns and respect their wishes. In today's world of diverse cultures, it is necessary for all of us to be respectful of other people's view of medical treatments, customs, and beliefs, regardless of our own beliefs. Sometimes the most important thing we could do for our patient is to offer them a hug or an empathetic ear. Tick-tock, tick-tock. The man receives treatment and walks out of the hospital independently. Tick-tock, tick-tock. The woman underwent surgery and is recovering at home. Tick-tock, tick-tock. The child receives treatment and returns home with grateful parents. Tick-tock, tick-tock. Team members rejoice for a good day of work. Tick-tock, tick-tock. Thank you.
Hello, good evening. My name is Heather Heath, and I've been employed here for 13 years, and I'm very grateful to have a job here. And I'm with a respiratory therapist, so I'm a respiratory team. Hello, team. My essay was Make a Difference, and I truly believe that make a difference, when I read this to you, was from something that I really am, dear about. So, make a difference. What does right care right now mean to you? Each person has a different view on what is right. Does it involve a gender? Does it involve an age, belief, or religion? Will you be the one giving or receiving the care? Will you be the one who will brighten a life, or will you be the one who just walks by? Each day is a new sunrise, and in critical care, we bring that sunrise to patients. Right care can be as simple as giving a listening ear to a patient, family member, support member, or even our multidisciplinary team. Just taking 5 minutes of your time seems like a hard thing to accomplish when you're trying to do a task. However, it can make the difference in the healing process, mentally, emotionally, spiritually, and/or physically. Right care is researching and finding a solution. Each person has a unique and incredibly complex system. In critical care, we cater towards the individual needs of each person. As healthcare members, the resources are available for trying new techniques, using new ideas, and taking on challenges. As healthcare professionals, our goal is to find the best solution to improve the outcome or dissolve the illness. Giving the right care changes the lives of those we are touching, including our own. Do you recall a person who touched your life, even as young as a child? It leaves a huge impact on the person we are today. People young or old have the ability to heal one another regardless of age. Age can represent experiences, wisdom, and the ability to teach and encourage the next generation. Human society has many beliefs and religions. Giving the right care involves being compassionate and doing everything necessary to provide dignity, regardless of what beliefs are taught and enforced or how the higher power is inferred. Every person has the ability and opportunity to provide right care right now. Will you step up and take the challenge? Will you be the difference? Thank you.
Thank you, Dr. Akawili and Dr. Sweeney. Very, very exciting and inspiring, really. I'm particularly inspired to hear from Anu, Ida, and Heather. Congratulations to all of you. It's wonderful to hear those stories, wonderful to hear those kinds of principles elucidated in ways that are meaningful to us and to patients particularly. Thank you very much. Appreciate all that you do. That's a critical part of the hospital. We call it critical care, but it's critical to the hospital. Thank you very much. We'd now like a consideration of the minutes for July 9, 21, 23, and 28 of 2014. If I could have a motion.
So moved.
Second.
I have a motion and a second. Any discussion on that at all? Christine, if you'd take a vote on that.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen.
Aye.
Motion passes. Thank you. It's now time for oral communications. I have several cards here, and we'd invite those to come up now and speak. First of all, we'd like to hear, first of all, I would like to apologize if I mispronounce any names. I will make my very best efforts, and sometimes those aren't enough, but I will try my very best, and I apologize if I mispronounce someone's name. First one is very easy, Jeanette Downs. If you'd come up and address us here at the microphone. I'm sorry.
Right here.
Yes, this microphone right here. Jeanette, before you start, need to do all that we can to limit your remarks to about 3 minutes.
Okay, that won't take that long.
Christine has a timer here, and she'll remind us of that, but it would help us a lot if we limit you to 3 minutes. Thank you very much.
Thank you. Good evening. My name is Jeanette Downs. I'm a CNA on 5 West, and I'm also a member of the SEIU, UHW, and I have worked for the hospital for 8 years. Recently, hundreds of our coworkers and I, representing a majority of the SEIU caregivers here at Washington Hospital, signed a petition for your attention. It reads as follows. We, the undersigned SEIU UHW members, and care providers of Washington Hospital stand together in support of our SEIU UHW bargaining team. We are committed to providing our patients and communities with the best care possible. We call on you, the elected Washington Hospital Board of Directors, to 1, ensure our community members continue to have access to the highest quality care, and 2, direct our administrators to negotiate a fair agreement that maintains current contract standards and retains a skilled workforce. Here in my hand, I have copies of the petition signatures and a copy of the petition. Thank you very much, and who would I give this to?
Deliver it to
Okay.
Christine. Thank you, Jeanette. I'd like also now to hear from Nina Baniani. How'd I do, Nina? Did I come close to that?
Pardon? Baniani, that's right.
Thank you.
Good evening. My name is Nina Baniani, and I'm a respiratory therapist at Washington Hospital and a member of SEIU UHW. I have worked for Washington Hospital for 20 years. As a caregiver in the hospital, we are committed to providing quality care for our patients and our community. Through our union, we routinely speak up over concerns over staffing for our patients. We've lobbied the city government extensively to encourage them to find a solution to our crosswalk issue. We've partnered with Washington Hospital to put on a ACA enrollment event in this very auditorium, where 100 community members were connected to newly expanded health care coverage. We're working with hospital employers all across the state to transform Medi-Cal to provide better care for those using the program and to make it more efficient for providers like Washington. Our track record is clear. When hospital employers and the SEIU UHW members work together, great things can be accomplished. Thank you.
Thank you. I'd like now to hear from Abby Aguado.
Hello, my name is Abby, and I am a telemetry technician at Washington Hospital. I've been a member of the CEIU UHW. I have worked for the hospital for the last 10 years. I currently support myself, my spouse, and my 2 children under the hospital's provided benefits. I also make about $50,000 a year. Under the current hospital proposal, Washington Hospital wants me to pay $2,000 more a year for my current benefits. Combined with the rising cost of living in the area, I do not know how we would make ends meet. It's not right that I or any other caregiver should be put in a position where we have to choose between paying our mortgage and paying my child's health care benefits. Washington Hospital has the wrong priorities, boosting the CEO's pay and benefits while trying to raise healthcare premiums and cut retirement benefits for hospital caregivers is just wrong. Thank you.
I'd like now to hear from Louis LeGrand.
Hi, my name is Louis LeGrand. I actually work at Sutter Solano Medical Center, but someone reached out to me and told me that they had an emergency here, that he didn't feel comfortable reading this to the board because of fear of the CEO outrageous pay, so he asked me to read it. So he said, my name is John Doe. I am a blank at Washington Hospital and a member of SEIU UHW. I have worked at the hospital for X amount of years. Washington Hospital says that it has been in financial danger for years, but our CEO is one of the highest paid public officials in California, receiving more than $1 million in taxpayer dollars, including bonuses, more than $428,000 over the last 3 years. After hearing from my coworkers, especially those who can't afford the massive increase in health insurance cost, I am outraged. While management at Washington Hospital refuses to work with us to find solutions to save caregivers' health insurance and retirement, The district is paying our CEO double the salary of the President of the United States, including massive bonuses, brand new cars, and a lifetime premium free health insurance. This is just wrong. We have other solution. We're calling on the board to work with caregivers to approve putting an initiative on the ballot that will cap the executive compensation for nonprofit hospitals. If the board really believes taxpayers approve of paying outrageous CEO salaries, they should put this initiative on the ballot. Let the people of the district vote and tell the real story. Thank you.
We'd like now to hear from Loretta Stevenson.
Hello, my name is Lenitra Stevenson. I am a PCT at Kaiser Fremont. I've been working there for 11 years. As a follow caregiver, I can't believe you would force caregivers at this hospital to beg and plead to protect affordable health care for their families while keeping your CEO one of the highest paid nonprofit executives in the state. Washington Hospital CEO and top executives are clearly standing up for only their own lavish salaries and perks, even if it puts the welfare of patients and caregivers at risk. SEIU UHW represents 45,000 Kaiser workers in this state, and we are not going to sit by and let administrators at Washington Hospital undermine the basic standards of healthcare workers in the area we have fought hard to achieve for. Keeping good jobs in our hospital opens opportunities in our community, raises the standard of care, and allows caregivers to build a better life for our families. Whether it's a board meeting, on the picket line, or at the ballot box, we're committed to quality care, and we will support our fellow members at Washington Hospital to oppose these unjust cuts.
Are there any other comments from the public tonight? I'd like to make just a couple of remarks tonight. We appreciate the employees and others that have come here to address the board. As you know, a public board meeting is not a place for labor negotiations. Labor negotiations belong between the CEO and her designated people and the union. We must also honor the Hospital Resolution 331A, which states that the hospital and union are contractually obligated to negotiate one with another, and that SEIU represents those employees belonging to the union. We sincerely hope that the negotiations can benefit both parties. We recognize that it's easy not to see eye to eye, but it's our hope that these negotiations will conclude in an amicable and respectful manner. I'd like also to comment for just a minute on the CEO salary that was brought up tonight. The district has a long-standing philosophy of wage parity for all employees of the hospital, and that includes the CEO. Wage parity means that the CEO is not paid at the top of the scale, nor is she compensated towards the bottom. We spend a great deal of time annually analyzing the CEO salary. We have retained companies, Integrated Health Strategies being one of them, to give us information and accurate numbers as to CEO salaries. Integrated Health Strategies represents 350 major healthcare systems, 1,000 hospitals, and over 17,000 executives. We look at those numbers, we work through those numbers, and come to a conclusion that is fair and honorable with our CEO and honors our philosophy of wage parity. I just felt like it was important to get some of those thoughts out. We will now move to our written communications and have Dr. Lenny, our Chief of Staff, report.
So I'm going to be reporting the credentials action items for July. We had quite a few new applicants and appointments. Dr. Kevin Bauer, cardiology. Dr. Dennis Bouvier, internal medicine. Dr. Walter Chang, internal medicine hospitalist. Dr. Eric Chen, radiology. Dr. Amir Daska, podiatry. Dr. Lubna Hussein, emergency medicine. Dr. Michael Harmon, radiation oncology. Dr. Sunita Kaiser, pediatrics. Dr. Amy Kane, obstetrics and gynecology. Dr. Rishi Kapila, internal medicine hospitalist. Dr. Simon Kim, urology. Dr. Kirk Lin, gastroenterology. Dr. Becky Luo, internal medicine. Dr. Bhavna Malik, infectious disease. And Dr. David Miller, infectious disease. Dr. Tushar Ranchode, ophthalmology. Dr. Andrew Saunders, pediatric hospitalist. Dr. Anamika Sharma, pediatrics. Dr. Stacy Solt, emergency medicine. Dr. Alan Spira, emergency medicine. Dr. Deborah Stern, pediatrics, neonatology. Dr. Soheil Sood, pediatrics. And Dr. Francis Wong, anesthesiology. For medical staff reappointments, we have Dr. Sarkis Bonnie Paulson, family medicine. Dr. Lisa Buhar, radiation oncology. Dr. Elwin Kabebi, medical oncology. Dr. Varun Chawla, nephrology. Dr. Ki Chi, nephrology. Dr. Alexandra Cole, pediatric hospitalist. Dr. Stephen Curran, family medicine. Dr. Koinis Enix, cardiothoracic surgery. Dr. Mai Gay, obstetrics gynecology. Dr. John Giddens, internal medicine. Dr. Kadir Halimi, emergency medicine. Dr. Sylvia Wong, family medicine. Dr. Shakir Haider, gastroenterology. Dr. Suvarchala Kampela, internal medicine hospitalist. Dr. Coy Lam, emergency medicine. Dr. Ricardo Molina, orthopedic surgery. Dr. Kavita Raj, hematology oncology. Carrie Robertson, physician assistant. Dr. Vandana Sharma, medical oncology. Dr. Allison Slack, obstetrics gynecology. Dr. Arun Srivatsa, gastroenterology. Dr. Shalini Sundar, nephrology. And Dr. Daniel Sweeney, intensivist critical care. We have a transfer in staff category. Dr. Varun Chawla is going from courtesy to active staff. We have one physician who's completed proctorship and advanced in staff category. That's Dr. Ricardo Molina, orthopedic surgery, who has completed proctorship and is going from provisional status to active. And that's it.
I'm sorry, did you go through the temporary privileges?
No, we had 5 physicians with temporary privileges during the period. Dr. Lubna Hussein, emergency medicine. Dr. Tushar Ranchode, ophthalmology. Dr. Alan Spira, emergency medicine. Dr. Deborah Stern, pediatrics neonatology. And Dr. Soheil Sood, pediatrics. And all 5 of those physicians are in the appointment category as well.
Good. Thank you. Thank you. Do we have a motion on that item?
Mr. President, I move for the approval of the medical staff credentialing action items.
Thank you. Do we have a second?
Second.
We have a motion and a second. Christine, if you could take a vote.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Eben.
Aye. That motion passes. Thank you, Christine. We'd like now to take up a discussion of the 2013-2014 grand jury, Alameda County grand jury report. Nancy, if you'd like to.
I'll begin by introducing the subject. This is an opportunity tonight for the board members to provide their preliminary thoughts on the letter from the grand jury. Some initial comments, as you might recall, were made on June 25th by our chair, Dr. Stewart. And this is a time for the other board members to provide comments as they might choose to make. But before you make your comments, I wanted to tell you what the anticipated schedule for formal response is. The district's formal written response is due no later than September 23rd, 2014. At the September 10th, 2014 meeting, we will have a draft response for your consideration and approval. I also wanted to let you know that we've already started implementing some of the recommendations of the grand jury. We're now posting the district's and DEFCO's minutes and the board packets online ahead of the meetings. The grand jury also wanted us to eliminate the sign-in sheet, and I wanted to clarify that this was never intended to give anyone the impression that signing the sheet was mandatory. We have already made recommendations to adjust the process and make it clear that no one's required to sign in order to attend or participate in our meetings. One of the uses that we can make of this sign-in sheet is to find out if people do want to receive information about the district by email or by snail mail, and we can respond to those requests that way. Staff is also working on making other recommendations to improve the required transparency, and we'll describe those in the upcoming board meeting. And with that, we're ready to listen to the comments of the board regarding the letter, its findings, or recommendations. We'll take notes carefully this evening and have your comments in mind as council helps us develop a written draft for your approval in September.
I want first to repeat some of the things that I said in our last review of this subject. I think it's very, very important to reassure the district residents that the care and services provided by Washington Hospital were never part of this grand jury inquiry. In fact, the report states that for more than 50 years, the hospital has provided state-of-the-art medical care to the community. The items involved in the grand jury report we're going to discuss somewhat here tonight, and we will be acting on those. But I wanted to make clear the fact that this report has nothing to do with the quality of care at Washington Hospital. First of all, I'd like to ask if there are any public comments on this before we begin with board comments. I'd be anxious to hear from anyone who has something to say on that. There appears to be none. I would open that discussion now among the board members and invite your comments, each of you, on the parts of that report. Perhaps we could start with you, Pat.
Thank you. First of all, I want to thank the members of the grand jury for their work. It's always good to hear how members of our district, as well as others outside of our district, see us. And we are always interested in how we can improve the way things are done. I was pleased that the grand jury recognized the hospital as an asset to the community. There are two issues that I have comments about. Number one, I respectfully disagree with their suggestion for term limits. I have worked in healthcare for the majority of my adult life, and I have seen tremendous changes, and more are expected. It is the combined institutional memory and healthcare experience of each of our members who enable this healthcare system to be that community asset. One of this healthcare system's assets are its long-term employees. In the recent past, we recognized an employee for 45 years of employment. Long-term employment is not an uncommon thing in our healthcare system, and in my opinion, it's a factor in why this healthcare system receives recognition by a variety of groups. Why should the board be considered any differently? We live in the district, this is our hospital too. During each election cycle, the public has a voice in who they want to choose. That in itself is a method of limiting terms. There was no opposition to 3 of our board members who had filed for re-election this November. To me, that is a strong affirmation of how the residents of this district feel about the direction we are taking. The second issue, and my comments relate to complying with requests for information. We are in a hybrid time between electronics and paper information. These requests present unique challenges since we are a very complex healthcare system. The staff has attempted to be as helpful as possible when dealing with these releases. Some of the releases have resulted in reams of paper, or rather boxes of paper, and I'm not sure how to quantify the electronic information. I am confident that staff is constantly taking steps to streamline this system. I deal with similar issues in my work life with requests for release of medical record information. Between the paper medical record and the electronic medical record, it is not a simple or easy task. All we can do is try to make it as smooth as possible. Again, I'd like to thank the members of the grand jury for their observations.
Thank you, Pat. Dr. Epen, do you have comments you'd like to make tonight?
Well, I think the grand jury report is out there, so I don't need to discuss that. But like Bernie said, there's nothing in the report that says anything about the quality of care, because we do believe in patient-first ethics, and I think that's been very highlighted, and nothing negative regarding that is in the grand jury report. But having said that, I've worked in about 4 different continents, and I'm proud to be here now, an American, where there's so much of transparency, where governance can be investigated, and I think that's the purpose of the grand jury. So I'm definitely not taking it lightly. Whatever corrective measures that could be done, I'm sure, along with my board members, it'll be done, and it's in the process, like it was mentioned, it's already being initiated. We as elected officials, we have a moral obligation and a responsibility, and sometimes the responsibility overrides the moral obligation. And when that happens, sometimes there's a perception. A lot of things are perceived, and when you make a report of this nature, especially when it is a grand jury, and that's the very term grand jury is, that is much larger jury, that's why it's grand jury. There may be certain illusions and perceptions that probably need to be clarified. But like I said, anything that needs to be fixed, we are only happy to do that. And before I close, I'm reminded of a quote by Scott Adams. He said, "Creativity is allowing yourself to make mistakes. Art is knowing which one to keep." I can assure you that we won't keep any mistakes. Anything that need to be corrected, we will do. And that's definitely an assurance from us. Thank you.
Thank you, Dr. Epen. Dr. Nicholson.
Thank you, Dr. Stewart. First of all, I'd like to express my appreciation to the grand jury for their thoughtful review and recommendations that they made, although I don't agree with all of them. But clearly they put a lot of thought into the work that they did, and I think we should all benefit from that work. One of the things that they suggested is term limits, and I know it would be rather self-serving of me to say that we should not have term limits. However, in managing the hospital and looking at the operations of the hospital, this is a very complex system. And it's not only a complex operation that we have here at the hospital, we operate in an incredibly complex environment. Changing healthcare law, changing healthcare policy. And we also operate in a competitive marketplace. So I think it's very beneficial that the district have board members who are fully informed, have a deep understanding, and have an intimate knowledge of the institution so that the board may guide it best. I would concur with Pat's comments about the public and electing board members. I put a lot of faith in the public. They usually get it right. And I think it would be a disservice to the public to not give them full freedom to choose whoever they wish to serve on the board. The public has every opportunity to not to vote for us, to recall us, to express their displeasure in any way they wish. But I would say that leaving the discretion of who sits on this board in the full hands of the public is the thing that will serve this board, this hospital, and this community best long term. With respect to the other issues that the grand jury addressed, some of these revolved around meeting the requirements of the Ralph M. Brown Act. And this has to do with the public meetings. We've always had a sentiment here on the board that we were trying our best to meet those requirements, complex as they are. And they're made even more complex by the fact that we are running a hospital and not a sewer district or a city, not a water district, but we're running a hospital in a complex competitive environment. This requires frequent meetings in closed session to discuss where we stand and where we're going to go. It would be a disservice to the district not to respect the necessary confidentiality which is required of those discussions. Also, we discuss issues with respect to medical staff and patient care, and those must also be held in a confidential environment. Those are all appropriate for closed session discussions. That being said, it's my desire as a board member that we fully respect and honor and follow the Ralph M. Brown Act in every way that we can. And I would encourage the board to look to see, and I know that staff will help guide us on how to do this, but look to see what are really the best practices in public agencies to see how well we're doing and where we can do better. In Washington's hospital's mission statement, there is a phrase that says that we will adopt identified best practices. This is one thing I think our board should seek to do, and to work to identify the best practices with respect to following the Brown Act, and then make appropriate corrective measures so that we are in full compliance. I think we should follow the spirit of the law as well as the letter of the law. I think those are the comments that I would that I have most concerns about.
Thank you very much. I'd like to just make a few comments myself. Again, on the closed sessions, there's always a worry in the community, and we've been criticized sometimes in the newspapers for holding closed meetings. Being a public agency, to hold a closed meetings means to many people we're trying to keep a secret. And it's not a matter of trying to keep a secret, it's a matter of protecting private, very personal information. Things that are required by law to remain confidential. There are laws in the country that state that patient care, patient relations between doctors and patients are strictly confidential things. We cannot discuss those in open session, and I'm sure we're all grateful that our appendicitis is not discussed in this meeting. And so there are other things that are very, very necessary for us to discuss in closed sessions. One of those happens to be that this hospital is a public hospital, but we operate in a very competitive environment. Just down the street is Kaiser Hospital. Just down a little bit further is Palo Alto Medical Clinic, Sutter-owned hospital, or Sutter-owned group. Those are competitors. We are working to provide the best care possible for our community. But at the same time, we need to stay ahead of those that are around us. And those kinds of decisions are decisions that we can't disclose to our neighbors. If we do that, it would put us at a distinct disadvantage. Dr. Nicholson alluded to that by saying that we're not a water district or a sewer district or one of those other monopolies that provide services certainly to the public, but they have no competition. I think sometimes some of us wish they did. But we're a different kind of public agency. We're very, very anxious to respond in a respectful and very, very thorough way to this grand jury report. I just tell you again that Nancy Farber and I both appeared before that grand jury. We went up to Oakland and individually at different times and spent a couple of hours each of us talking with them. I found them to be a group of good people. I found them to be a group of people that are interested in the best for our communities and for the public agencies that serve those communities. And their report is one that we wish to respond to in a very effective and good manner. It was also mentioned in the report that they were anxious that we comply to the Public Records Act. I wish that that we could, at this board meeting tonight, produce all of the materials that have been provided to other agencies and to individuals in our communities. I just tell you that it might half fill this room. It is a huge amount of documents that we have tried our very best to comply with the law in every way. We feel that we're making a very, very strong effort in doing that. They also have suggested that we make our board packets, the information for these meetings and minutes of these meetings available online. And I smile at that because that's just one of the changes of our time. That all of us every day now spend many minutes a day online doing things, and the hospital will come up to speed on that very quickly, and we will very, very quickly comply with that and put all of the necessary documents in a situation where they could be read online. There was a comment made that on there that we've already talked a little bit tonight about our CEO contract, that be that be a public document. And I just wish here once more to say tonight that is in fact a public document. Personally, I'm very grateful that my personal employment is not a public document. But in a public institution like ours, we are required to have things like that be public documents. And that is, in fact, a public document and is accessible to the public. Are there any other comments that need to be made tonight in regards to these issues?
I wanted to just address very briefly some of the laws. A more comprehensive list will be compiled for the report next month. But I wanted the public to be aware there are actually laws that prevent us from disclosing information. There are federal laws like HIPAA. There are special laws for patients covered under the Lanterman-Petra Short Act, and those rules are very strict. The State of California Health and Safety Code, and breaches of the laws in that code are subject to fines that begin at $75,000 and go on up. And if you've had more than 3 instances of breach, they fine you at the maximum level, and you remain subject to the fines under the maximum level for a specified period of time. And this isn't a group of breaches, it's every instance of breach. So the federal and state laws are hugely a factor in how information is dealt with. We do peer review, privileging, and credentialing with the medical staff. Those things are protected and are done in the sanctity of private meetings. The outcomes are published. You hear them at this meeting when Dr. Lunny presents the report on privileging and credentialing. The peer review matters are subject to absolute sanctity of privacy. If we fail to provide for that privacy, we could be sued. Personnel actions of a disciplinary nature are also subject to confidentiality. Real estate transactions, legal advice and consultation, strategic planning, risk and claims are also all provided confidentiality until a decision is made around any one of those issues. The decisions are then public at this meeting. But I think that there's a general misunderstanding of how regulated this industry is as it relates to information that flows from the operation of a hospital. A hospital is not just one business, it's many businesses. It's a hotel, it's a clinical lab, it's a clinic, it's emergency services, it's a radiology service, it's an organized medical staff. There is not just one business, it's truly complicated and perhaps the most regulated industry in the United States. And we are duty-bound to follow all of those regulations. We'll have a more comprehensive list of them included in the response to the grand jury.
I don't want to sound like a broken record, but I think it's very, very important for everyone, especially the public, to know that, yes, the Washington Hospital is a public agency, the hospital is owned by the residents of the district. We are a public agency, but we're a lot different in all that we do and all that we're regulated on and in all that we work with than any other public agency. We are truly a different animal. I'm in my 12th year and serving on this board. When I entered the board, I had been a member of this community for 40 years and a practicing dentist for many years. I felt like I knew how to deal with insurance companies and I knew how to provide care, but the learning curve was incredibly steep in finding out how to serve on the board of directors of this organization. I feel today, even after 12 years, that I have just the barest minimum of understanding the difficulties and the very, very complex dealings that we make in this organization. I respect anyone who is part of this organization and who works so hard to serve and work for the public. We're anxious to, as I said, reply to the grand jury in ways that they'll understand and in ways that they will see how we are working very hard to do what we need to do in this community. I thank everyone who's made any comments on that. Are there any more that need to be made tonight? Good, then we'll move on to our Service League report. We get to hear something much lighter now, Gail.
Hopefully. Well, volunteers have been busy this summer helping at various special events. They carried the Washington Hospital banner in the 4th of July parade. Several volunteers have been enjoying the music at Lake Elizabeth while helping in the Washington Hospital tent, passing out popcorn and information during the Concert in the Park event. We had 24 students who had the opportunity to assist and have exposure to science research in the neuroscience field at the Neuroscience Symposium. There were several volunteers who helped WIA's biggest fundraising event, collecting the $5 fee at the Washington West parking lot during the Fremont Art Festival. Volunteers also assisted in updating the hospital department's hazmat binders. These volunteers also staffed in their regular assigned areas in the hospital. So thank you to all the volunteers who always step up to the plate and help whenever needed.
Thank you, Gail. Nice to have the volunteers.
Yes.
It's a very, very valuable part of the hospital. And I feel sometimes that we can't thank you enough for the work that you do. We appreciate all that you do. Dr. Lunny, if we could have our medical staff report.
Yeah, our medical staff has grown over the past month to 516 total members, 330 active members, 64 who are provisional active, undergoing proctorship, 31 courtesy members, 3 consulting members, 66 ambulatory medical staff, 19 allied health professionals, and 3 administrative. And we currently have 23 applications in process.
Thank you. Thank you. 500.
516. So.
Keeps going up.
Yeah. Nancy, if we could have our hospital calendar presentation. I'd
We'll start
appreciate
with the video, please.
Past health promotions and outreach events. The 2014 Central Park Summer Concert Series kicked off on Thursday, July 10th. Washington Hospital is the co-presenting sponsor. All concerts are held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. Washington Hospital has provided health information and health screenings during the 6-week concert series. Representatives from Cardiovascular Services, Birthing Center, Infusion Center, Community Outreach, and the Women's Center have been present. One remaining concert will be held on August 14th and will include representatives from the Intensive Care Unit along with information on advanced healthcare directives. On July 19th, Washington Hospital and the Taylor McAdam Bell Neurosciences Institute hosted the 7th Bay Area Symposium on Advances in Neurosciences. World-class neurologists, neurosurgeons, radiation oncologists, and other healthcare professionals spoke at the symposium. Nationally and internationally recognized experts discussed a wide range of topics focused on neurological diseases, disorders, and treatment approaches. The program coordinators were Dr. Sandeep Kunwar, neurosurgeon, Dr. David Larson, radiation oncologist, and Dr. Moses Tagioff, neurosurgeon. 127 people attended. On August 7th, as part of the free Diabetes Matters education series, Kathy Weinberg, RN, presented What to Expect When Hospitalized with Diabetes. 7 people attended. On August 9th, Washington Hospital participated in the Ohana Health Fair presented by Tri-City Health Center and the Fremont Unified School District. Washington Hospital provided 28 bone density screenings. Over 300 people attended. Upcoming health promotions and community outreach events. On Tuesday, August 26th, from 1 to 3 p.m., Dr. Jason Van Tassel will be presenting Treatment Options for Sleep Apnea. On Tuesday, September 2nd, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jane, cardiologist, and Doug Van Houten, RN, will present Stroke Prevention and Other Disease Processes and Healthy Lifestyle, Be Smart and Avoid Stroke. On Thursday, September 4th, from 7 to 8 p.m., as part of the free Diabetes Matters education series, Cynthia Hunter, RN, will be presenting The Diabetes Domino Effect, ABCs. On Monday, September 8th, from 7 to 8:30 p.m., Dr. Victoria Leapart will be presenting Restoring Balance, a 6-week stress reduction program. The Washington Hospital Healthcare Foundation Report. On October 11th, the Washington Hospital Healthcare Foundation will host the 28th annual Top Hat Dinner Dance. This year's gala will be co-chaired by Rod Silvera and Skip Turner, the owners of Professional Home Care Associates and Neurosport, and Dr. Jan Hensdorf, Chief Medical Information Officer at Washington Hospital. The trustees of the foundation have designated the proceeds from this year's Top Hat Gala towards the Washington Special Care Nursery, which is affiliated with UCSF Benioff Children's Hospital, San Francisco. This unit in the hospital cares for babies born prematurely or with life-threatening conditions. Funds from the gala will support patients' families and provide technology upgrades. To reserve seats at Top Hat or inquire about sponsorship opportunities, please call the foundation at 510-791-3428. Washington Hospital Employee Association, WIA. On July 30th, WIA held a reception to recognize Caitlin Kopeski, the recipient of the 2014 Don Pickenpaugh Memorial Scholarship in the amount of $2,000. Caitlin is the daughter of Suzanne Kopeski in patient accounting and will attend Cal State University Fullerton in the fall, majoring in communications and business. On August 2nd and 3rd, WIA held their biggest fundraiser of the year. During the Fremont Festival of the Arts, employees requested a $5 donation for festival attendees to park in the Washington West parking lot. The event raised over $7,000. Proceeds will benefit charitable projects and organizations in the district. Washington on Wheels, WOW, Mobile Health Clinic. During the month of July, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center, the Fremont Family Resource Center, the Silliman Activity Center in Newark, the New Haven Adult School, and the Ruggieri Senior Center, both located in Union City. Washington on Wheels continued with the summer's free glucose screenings at the Niles Canyon Mobile Home Estates, the Newark Library, and Centro de Servicios in Union City, as well as all regularly scheduled community sites. In July, WOW provided glucose screenings to 178 individuals. The total number of community members receiving health care from the Washington on Wheels Clinic during the month of July was 285. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was July's most viewed webpage with 16,146 views. InHealth, Channel 78. During the month of July, Washington Hospital's cable channel 78, InHealth, taped new programming, including the Neuroscience Conference. InHealth aired new programming, including the July Board of Directors meeting and a Diabetes Matters program titled Diabetes Update 2014. Awards and recognitions. U.S. News & World Report has again recognized Washington Hospital as one of the best hospitals for 2013-2014 and is rated as the 6th best hospital in the Bay Area. Washington Hospital has continued to be recognized as high-performing in 7 specialties, including gastroenterology and GI surgery, geriatrics, gynecology, nephrology, neurology and neurosurgery, orthopedics, and urology. Additional news. Washington Township Healthcare District Board of Directors member Patricia Danielson was elected as Vice President of the Alameda County Special Districts Association, ACSDA. Ms. Danielson has been affiliated with the ACSDA for more than 10 years. As the Vice President, Ms. Danielson will serve in a backup role as necessary when the President cannot fulfill his duties, and will serve in a dual role of Treasurer and will oversee the Association's finances. The ACSDA includes 17 member districts and 5 associate member districts, and prior to her election as Vice President, Ms. Danielson served as ACSDA's at-large officer. On August 6th, students and faculty from Taipei Medical University visited Washington Hospital. The main purpose of their visit was to provide students with the opportunity to gain specialized knowledge in the field of healthcare administration. A total of 11 delegates met with Washington Hospital staff and toured the facilities. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070. And please follow us on Facebook and Twitter.
Nancy?
Before I announce our Employee of the Month, I have another announcement which should make many residents of the district very happy, and most certainly our medical staff. Today I signed the contract with Aetna. After protracted negotiations, we were successfully able to reach an agreement which provides for the district appropriately. Now I'm very pleased to present the, okay. Thank you, David Haney. I'm going to talk a little bit about our Employee of the Month, Elizabeth Ragusa. Her mother works here too. You should be aware that her mom is a nurse in maternal and child health. She's been working with us since 2011. She started in the outpatient registration area as a patient greeter. She soon moved to the finance department cashier's window later that year, and we knew she'd be a valuable resource to our patients and for the hospital, as she had such outstanding customer service skills, and she does. She has a way about her. She has an amazing smile that never quits and a bubbly personality that puts people at ease, and she's developed a rapport with our patients that come monthly, and they call her Gal. Elizabeth is amazing to work with. She's very self-motivated, organized, and she takes enormous pride in her work. And she gives more than 100% all the time. She is extraordinary, she truly is, and a joy. She's the first face that greets our patients and represents not only the face of patient accounting, but Washington Hospital as well. She takes pride in her work. She always says yes when asked to do something, and she does it with a smile. It was recognized early on that she had a lot of potential and that there was much more she could do. She's taken on so many more tasks with little or no training and has done an excellent job. She hasn't missed a beat. She lives in Livermore with her parents, sister, and brother. And as I mentioned before, her mother is an obstetric nurse here at Washington Hospital. She grew up raising animals and was a part of 4-H. And she loved raising her animals, and a lot of them were purchased by Washington Hospital and used by our food services department. She's a very special Employee of the Month, and I don't think she stopped smiling yet. She was so pleased to be recognized this way.
Thank you, Nancy. We'd like now to hear our construction report from Ed Fayen. Anxious to hear that, Ed.
So I have a We received our bids on the parking garage right at the beginning of the month, and the bids were, unfortunately, we had subcontractors that were missing from the bidding. In other words, we had pre-qualified certain subcontractors and none of them bid for some of the work. So we are out soliciting those firms again to get bids in so we can evaluate those and then move forward with it. So we anticipate having final bids that we'll have a chance to review and make sure they're complete, and then bring to the board in mid-September in an open session. So that's our plan right now, and that's my status. Okay. Thank you.
We're ready now for a quality report. Mary?
We wanted to talk a little bit tonight about our intensivist program here at Washington Hospital. Some background just to describe, first of all, what is an intensivist? An intensivist is a specialized physician who directs a multidisciplinary team in the care of the patient in intensive care to make sure they have the best possible outcomes. These physicians can be certified in surgery, medicine, neurology, anesthesia, or pediatrics, in addition to their qualifications that they already have in providing critical care medicine. There's a great deal of benefits to having an intensivist in your critical care 24/7. These patients tend to have improved survival rates, less complications while in critical care, and better staff satisfaction, and a shorter stay in the hospital. In the community, it is really an advantage to have this program in your critical care because it helps people when they come to the ICU make sure that they have appropriate, reliable care that's coordinated and use the best evidence-based therapy that's available by having an on-site intensivist around the clock 24/7. When patients come into critical care and their family members, some things that the community can focus on to take advantage of this program while they're here are discussing with the staff in critical care about our hospital family engagement program, which is the program that Dr. Sweeney spoke about earlier this evening. And we also have provided annual education to the community, especially related to our sepsis and palliative care programs. Those are always available for people in the community. A background on our program is that we have an ICU intensivist in the critical care, one every 12-hour shift. So 24 hours a day, 7 days a week. Since 2009, we have provided an intensivist in critical care. 100% of our intensivists are critically care board certified, and 3 of the 9 are neurocritically board certified. This really helps with the consolidation, consultants, and coordination of care. The program objectives are to really focus on making this a patient, family-centered care practice model that improves the quality of care. You'll hear that as a reoccurring theme throughout this with any patient care, especially in intensive care, that we really want to work to involve the families and the patients more in the family care and in the decision-making. And Dr. Akwili spoke about this earlier about making sure that these patients get the right care at the right time, and that the team comes together. So it's physical therapy, occupational therapy, the medical staff, nursing, those that they all work together, and with pharmacy. We always, like I've said, have made sure to provide this care 24/7. Patients shouldn't be impacted by what time they arrive to the hospital or what time somebody gets sick and comes in. If you come in and you're sick at 4 o'clock in the morning, you should be able to get the same care that you do at 12 o'clock in the afternoon. So that's why all these services are offered 24/7. And again, initiating the patient and the family into the program to make sure that we have shared decision making. Has a huge impact on patient outcomes. So we've worked on quite a bit of initiatives in critical care for this intensivist program. There's about 5 we would like to focus on, one being the patient family engagement initiative. We also have palliative care rounds, worked a lot around delirium and making sure that patients get up and have early mobility when they can. and identifying sepsis and treating it in the ICU. The patient-family engagement, I think, has been covered well here this evening by Dr. Sweeney. He did a great presentation for us, so we won't need to go over the details of that again. But moving on to palliative care rounds. So typically, a patient that needs palliative care is a patient that needs symptom management. They're chronically ill. They're not focused on treatment and cure, but they're focused on managing their symptoms and making sure that they're comfortable. So we have had a strategy focusing on educating the staff, on making sure that we are identifying who these potential patients are in critical care. There's a lot of interventions in critical care and a lot of activity and treatment that can go on. So it's important to round on these patients and make sure that if anybody's a potential for somebody who could possibly get palliative care, that we identify them early and get them into our program. We've been rounding on these patients weekly since 2009. It's been really effective in helping identify patients who could qualify for palliative care and have a better quality of life. Our results have been good for this. In the first quarter of 2014, we did have half of our palliative care decisions were actually initiated by an ICU intensivist. 16% were initiated by another physician outside of an intensivist, and 33% were initiated by the patient themselves, which really is reflective of this engagement of involving patients and families in their care, that they were involved and informed well enough that they were able to sort of refer and make their own decision to come into palliative care. We were able to lower the length of stay by 1 day in a quarter, so these patients are getting out of critical care sooner. And also, we have done less procedures on these patients. As I mentioned before, there's a lot of potential to intervene on these patients who really are just looking for symptom management. So we've been able to decrease unnecessary procedures being done and make sure that they're comfortable. Another initiative is working on delirium in critical care. Delirium is the sudden severe confusion and rapid change in brain function with physical mental illness. These patients have decreased muscle strength. They tend to stay in the ICU for a long time, and they have a higher rate of morbidity or mortality. The national prevalence is 25% of these patients in the ICU typically end up with some form of delirium. Most of them are ventilated, 26 to 50% are at higher risk for experiencing delirium, and 10 to 25% of patients who are not ventilated are at risk for this. So we focused on some goals to improve clinical practice and knowledge amongst the staff and the physicians, so that we could make sure that we were identifying delirium early on and treating it. Our strategy started around May of 2012. The idea was to come together and, like I say, educate the staff and the physicians, and then to start screening all these patients for delirium. We use a RAS CAM ICU tool. It's a tool that is a standardized tool that is used in ICU by trained people, nursing and physicians, to assess, are these patients alert, how sedated are they becoming more restless, more confused. So by implementing that, we were really able to make an increase in how well we caught patients who have delirium. So we showed that when we implemented this tool, we went from 14% to 70 to 85% people being screened for delirium, and more use of the medication Haldol that will treat the delirium symptoms. And that went from 10% to 19%. So it's better than sort of using a sedation and different types of meds. We also, they did a survey and found out that once we implemented this tool and started looking at delirium closely, a great more of the staff and physicians were educated and understood what to look for in delirium and how to catch it early. All of this led to a decrease in our ICU stay by 2 days, which is significant when it comes to looking at critical care patients. And more importantly, we were able to decrease mortality by 4.4% by identifying delirium early on and decreasing the risk factors. Another initiative was to look at getting these patients up and moving. Anytime a patient is in the ICU and they're immobile, that really can have an impact on making outcomes worse for them. You know, if you're immobile, you tend to get more pneumonia and risk factors for skin issues, that sort of thing. So it's important that even though somebody's that ill, that we still focus on what we're doing to move them. When you're looking at mobility in critical care, though, it's got to be done safely, slowly, and assessed properly. So the first idea was to make our goal to increase referrals to assess these patients for mobility and what level of PT treatment they needed. So we, in April of 2013, got a dedicated physical therapist in the ICU. And we assessed these patients on 4 different levels. Who can ambulate in critical care? Who can only get out of bed in critical care? Who can graduatedly sit up and dangle their legs? And then for patients who are very immobile, can we at least come in and do some range of motions with those patients to protect their skin and other things? So our results were good after 1 quarter. We did have a huge increase in referrals to physical therapy. In 5 West I, we went from 12% to 50%, so we more than doubled there. And in ICU, 24 to 50%. So these patients were a lot more accessible to getting PT. This led to a decrease in ventilator days also, which is also decreases the risk factor of patients getting ventilator-associated pneumonia. We've also looked at an initiative and focused really on sepsis management. Sepsis is, as of 2013, is the 10th leading cause in the United States. So this is a patient that comes in that is, their whole body is affected by infection, and it's life-threatening, has a high mortality rate, very important to focus on in critical care. In 2007, we were selected as a pilot site for implementing our evidence-based treatment for sepsis. And the main goal of that was to screen for these patients early. And if you can catch the sepsis early and treat it early, you have much better outcomes for decreasing mortality. A multidisciplinary sepsis team was formed in 2007 using a Moore Foundation grant that we got. And by implementing the screening, we were able to decrease the mortality by 36% over this last 5 years. All departments throughout the hospital, because we do this outside of critical care also, have been very compliant in screening for sepsis. So we've had a lot of success in the tool and catching sepsis early on, especially with pre-hospital identification also. We were able to lower our mortality rate by 18.2% in 2 years. We've also been accepted as a part of the Surviving Sepsis campaign from 2014 to 2015. This is a campaign that's used with Critical Care Society of Medicine, and it really just focuses on helping hospitals look at collecting data and participating in sharing our sepsis data to focus on decreasing the morbidity and mortality risks that come with sepsis, especially on medical surge units. The program results, I think, are really significant for what sort of effects we've had by implementing an intensivist in the ICU 24/7. Just really briefly, this slide has a lot of things on it, but if you look at the light blue, that's prior to us having our intensivist program in 2008, and you'll see that with everything with regards to physician management, to the whole multi-professional team, and to what we look at for quality, we've been able to improve our efforts in there. So our coverage is better for our physicians. And if you look at the multidisciplinary team, we've trained more nurses, improved our staffing, improved our daily rounds significantly, and since we began the program. Protocols in under quality process have increased and been used well enough to even exceed what Joint Commission goal expects, and definitely more use of technology and improved safety efforts. So in general, this is just a glimpse at the effects of the coverage and how well they've helped us out overall. Another way to look at the outcomes of this program is by looking at your quality indicators. So when you have the patients in critical care and you have devices in them, such as a Foley catheter or a ventilator, we looked at the patient outcomes to see, were we able to decrease patients who got infections from having a urinary catheter, like this box that is the catheter-related urinary tract infections. You could see that this data goes through basically 2013. The last 2 quarters of last year, we had 0 catheter-associated urinary tract infections, which is significant. If it's below the red line, it means we're better than other hospitals, similar hospitals in the nation. And so for the last 2 quarters, we've had a better than standardized infection ratio at 0, which is really a good outcome. And then our central line bloodstream infections, same thing. We were up a little bit through the beginning of 2013 in the second quarter there, and then it's continued to come down. We've implemented a lot of efforts there to make sure that the lines are being managed appropriately in critical care. We've also been able to decrease our ventilator days, like I mentioned before, which is this last box. The national benchmark median of 4.0 ventilator days, and we've been able to, you can see it sort of hover around 1.47 to 1.98. I spoke a little bit earlier about the mortality rates and how well we've been able to do with that. The mortality rates, because the mortality is high to begin with, the risk for it. So, but last quarter we were at 13.7, which is great. It's on the lower side of the benchmark. The future direction of this program, we continue to focus on ways to improve it. We have a lot of ideas coming up and initiatives that we're continuing to work on. One is we will always have our monthly clinical operations committee meeting to sort of discuss the day-to-day operations of this program and what we can do to improve it. The initiatives that I spoke of will continue to focus on and work towards creating new initiatives. And in the community, providing annual education, especially on sepsis, again, because like I said, it's got such a high mortality rate. Want to make sure that the community is aware of signs and symptoms of sepsis. ICU antimicrobial stewardship is looking at making sure that when patients are this ill, we're giving them the right antibiotic for the right duration of time. We have an antimicrobial stewardship committee here that meets monthly, and they do focus on how we're prescribing antibiotics in the ICU. And we also have a dedicated pharmacist there that helps and participates in this committee. And transfer guidelines, also how patients come into critical care and how they leave critical care. That's a really important transition, and focusing on how we can streamline that process and make sure that patients are safe and that they're not affected by their quality of care during those transitions. Glucose management is very big focus also in critical care, especially with patients who have cardiac surgery. I want to look at improving our protocols and our policies in the ICU to have strict monitoring of patients' glucose levels, especially, like I said, after surgery or for diabetics. And we're looking at creating mandatory consult criteria in the ICU and how we can improve that. And again, the theme is to continue to focus on patient family-centered care and the engagement of the program that Dr. Sweeney was talking about earlier. That's a big initiative, and we can already see where across the nation, and especially here with our program, we've been able to improve patient outcomes by having that, and patient satisfaction. Any questions?
Thank you very much.
Thank you.
Pat has a question for you.
Mary, would you please clarify if my understanding of delirium is correct, that it is a short-term condition?
I think that it can be short-term. In ICU, we're looking at it for just managing it during that time period in that admission and identifying it early and treating it early there. I think that's true. It tends to be, our focus tends to be on the short-term delirium in this program, yeah.
Is it mostly with is age-related?
I think people and elderly populations are at higher risk for delirium, yes.
Okay, thank you.
I can address
Thank you.
that for you, Pat.
Thank you.
It's quite interesting, the phenomenon of delirium. We always thought there was confusional states which occurred in the intensive care unit. Most of the time they do improve. But several studies a few years ago demonstrated that very often there were substantial long-term sequelae of delirium in the intensive, delirium which occurred in the intensive care unit, which had profound impact on the well-being of that patient in the years ahead. So those studies really led to the push to reduce the incidence of delirium, to help prevent delirium by being attentive to it, responding to it with early treatment, changing the modality of the medications that we use to reduce the length and severity of the delirium. It's still something that we see, but less so. And I think the most beautiful thing that happened in the Delirium Project here at the hospital was that you could actually see the staff recognizing it earlier and calling it for what it was, which led to early appropriate treatment for it. But it's a very serious condition which happens in some critically ill patients.
Thank you. The reason I'm asking is because for a long time, patients have been monitored in skilled nursing facilities for delirium. And the presentation of it was that it was more or less short-term, resulting from maybe new medications, like Dr. Nicholson was just speaking about, change in location.
That's huge.
Just
Change in
moving them
location.
from maybe their home environment to here could create a sense of delirium.
Definitely.
So that's where it was coming from.
Yeah, no, I think
Okay.
that's true. Yeah.
Thank you, everyone,
Thank
for
you.
the clarification.
Thank you again, Mary. Chris, I'd like to hear our financial report. Thank you.
Good evening. Tonight we will be reviewing the operational and financial results for June 2014. And we'll jump right into our statistics. Average daily census for June landed at 146. We had expected 167 in the budget. We had 905 admissions against a budget of 915. Patient days were 641 below budget at 4,380. Outpatient observation days were 248. We expected 383 for June. Our average length of stay for the month came in at 4.74. We'd expected 5.40. There's a lot of work being done around length of stay and in case management, and we're seeing the results of that. Looking at utilization, case mix index for the month came in at 1.563. We had 129 deliveries, which is lower than we've seen it in the last several months. We expected 152 in June. Joint replacement cases were 6 above budget. At 130, we had 21 neurosurgical cases against a budget of 14. And our cardiac surgical cases were 9. We had expected 13, and all that rolls up into our total surgical cases that ended up 24 below budget at 328. Our cath lab procedures for the month were 46 below budget at 359. And our outpatient visits for the month were 7,312. We had expected 8,170. The emergency room, again, lower than we've been experiencing, although it increased in July. 243 below budget at 4,226. Quick look at our cath lab activity. No big changes in the mix here. Peripheral vascular and cardiac continue to dominate the activity in there, with interventional radiology and neurointervention making up about 13% of the volume. Looking at productivity, our productive full-time equivalents for June came in 92.8 below the budget at 1,185.4, and that's about as low as I think I've seen it in my career here. Non-productive FTEs for the month were 195.4, giving us total FTEs 58.3 below budget at 1,380.8. Our FTEs per adjusted occupied bed, even though we did flex down quite a bit, came in a little bit above budget at 6.89 in June. Moving into the financials, total patient revenue came in $9.3 million below budget at $164,232,000. Our contractuals for the month came in almost right on budget at 76.6%, leaving us with net operating revenue about $284,000 below budget at $41,297,000. Something I'd like to note there is that includes about $2.3 million in meaningful use funds that we actually did not anticipate to qualify for until fiscal year 2015. But Kristen Ferguson and the meaningful use crew worked really hard this year and actually was able to attest that we have qualified for those funds in June, so we were able to recognize those monies in June. Operating expenses for the month came in about almost $2.6 million below budget at $39,454,000. We were pretty much lower across the board. Our salaries and wages were lower with our lower FTEs. Benefits, as always, were driven lower by our health and welfare expenses. And our provision for bad debt was about $638,000 below budget, as we saw the lower revenue and the shift going on between private and Medi-Cal that we continue to see. So we ended June with an operating bottom line almost $2.9 million over what we had expected at $1,843,000. Non-operating income for the month came in $730,000 below budget at $1,349,000, and of course $231,000 of that was driven by our lower property tax revenue, which is a good thing because we were able to secure better interest rates on our GO bonds than we had expected. We did have a $265,000 unrealized loss on our investment. So we end June with a total bottom line of almost $3.2 million. Quick look at the FASB format. This is the way the financial markets tend to look at us. Operating bottom line doesn't change at $1,843,000. We do pull out our unrealized loss on our investments and our property tax revenue to come with non-operating income from a FASB perspective of about $308,000 and a total bottom line of $2.151 million. So are there any questions on June results?
Just the fact that that's the best month we've seen in a while.
Nice to give good news.
Thank you. We could move on to our operations.
I'm here to report on the preliminary results for July 2014. We saw 925 patient admissions that resulted in an average daily census of 145. This was 0.3% higher than the budget of 922 admissions and 0.7% above the budgeted average daily census of 144. The average daily census recorded a year ago in July was 138. Our high and low census ranged from 163 down to 118 respectively. Outpatient observation equivalent days of 253 were higher than the budget of 248 by 2% and lower than in July of 2013 by 23.1%. Our average length of stay based on discharges for adults and children in July was higher than the budget at 4.93. This was higher than June's average length of stay of 4.74. We had anticipated 4.86 in the budget. In terms of births, we saw 136 deliveries in July compared to the budget of 140. I believe that the signing of the Aetna contract will be bringing expectant mothers back to the district. July's deliveries resulted in 275 baby days of care. Our newborns totaled 136, the same as deliveries for the month. For the month of July, there were 336 surgical cases, 2 above the budget. This included cardiac surgical cases that were 1 below budget, neurosurgical cases that were 3 above budget, joint replacement cases that were 6 below budget. All general surgery cases were above budget by 6. Inpatient surgical activity was below budget by 12 cases in total, while outpatient surgeries came in above budget by 14. By comparison to July 2013, they had 351 cases. Total surgical minutes, which drive operating room charges, were above budget by 254. Inpatient surgical minutes were below budget by 4.8%. Outpatient surgical minutes were above budget by 26.1%. 630 cases were seen at the outpatient surgery center versus a budget of 590, so they did quite well. For the month of July, total procedures seen in the cath lab were 557. We had budgeted for 559. Dr. Bruce Lynn was out of town. Otherwise, I think we would have passed the budgeted projection. Overall cath lab volume for July 2013 was 592 by comparison. Cardiac procedures were on budget. Peripheral vascular procedures were 5 above budget. Neurointervention procedures were 1 below budget. Interventional radiology and other procedures were 6 below budget. Overall inpatient cath lab procedures were 17 fewer than anticipated, and outpatient procedures were 15 more than expected. In terms of non-emergency outpatient visits, in July we had a total of 7,521. 19 were lower than budget of 7,540 and lower than July of 2013, which was 8,003. Emergency room recorded a total of 4,451 patients with a daily average of 144. This was 89 visits above the budget. Washington, Warm Springs, Newark, Nakamura, and Ohlone Clinic saw approximately 3,715 patients during July, 286 more than the budget. The total system emergency room and clinic visits for July were 8,116, compared to a budget of 7,791. Full-time equivalents for the month of July totaled 1,369.5, including 15.3 agency personnel. This was 5.2 lower than the budget. Productive FTEs were 5.66 in July, below the budget of 5.92. Total FTEs per adjusted occupied bed came in at 6.66, which is below the budget of 6.94. Productive FTEs were below budget by 8.2 for the month. Non-productive FTEs came in at 3 FTEs above budget. Preliminary information indicates that inpatient revenue for the month of July amounted to approximately $116.1 million, compared to the budgeted estimate of $115.3 million. Of this amount, 54.6% was Medicare, including Medicare HMO, and 21.2% was Medi-Cal. As you've noticed, the Medi-Cal numbers have been steadily increasing. The private pay, correspondingly, that category has been becoming smaller and smaller, and this is a direct result of the Affordable Care Act. This compares with budgeted inpatient revenue percentage of 57.6% Medicare-sponsored patients and 16.7% Medi-Cal-sponsored patients. So we're seeing more Medi-Cal than we had projected. Total government program revenue for July was 75.8% of the total inpatient revenue. We had budgeted it at 74.3%, so fairly close. Private pay revenue, which was the corresponding decrease to Medi-Cal that I mentioned, was at 0.8% of inpatient revenue versus a budget of 1.8%. Based on July's 4,483 patient days, 55.1% were Medicare, including Medicare HMO, and 20.5% were Medi-Cal, including the Medi-Cal HMO. Let's see, total government program patient days for July were 75.6% of total inpatient days. In terms of revenue for the month, it was slightly over budget by $752,000, or 0.7%. The outpatient revenue for July was also above budget by $6.3 million, or a 14.9% positive variance. This was due to higher levels of activity in both the operating room and the cath lab. So in summary, we had 3 more admissions and 2 more inpatient days than anticipated in the budget. Our surgical cases were above budget by 2, and cath lab procedures below budget by 2. Outpatient visits for July were 19 below budget, and ER visits were 89 higher than anticipated. Clinic visits for the month were above budget by 286, or an 8.3% positive variance. Total paid FTEs were below budget by 5.2 for the month and below the last 12 months average by 33.7 FTEs. The FTEs per adjusted occupied bed were below budget. Inpatient charges for the month were above budget by approximately $752,000. Outpatient charges were higher than the budget by approximately $6.3 million. So our total hospital charges for July are above budget by $7.1 million, or a positive variance of 4.5%. On July 31st, there were 154 days cash on hand. Total days revenue and accounts receivable at July 31st was 72.3. The increased days in account receivable is associated with Medi-Cal. The days revenue and accounts receivable excluding Medi-Cal was 71.1. Days in accounts receivable excluding the Alameda Alliance, which is also Medi-Cal, was 51.55. So there you see where the problem in collections lies. During the month of July, $1,168,418 of charges were approved or pending for charity assistance.
Thank you, Nancy. We now have a couple of action items to deal with. Dr. Nicholson, item A.
Item A, Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of a digital video recording system for an amount not to exceed $25,906. This purchase was included in the fiscal year 2015 capital equipment budget.
Thank you. Do I have a motion? Do I have a second on that?
Second.
We have a motion and a second. Discussion on that, Nancy?
I think the necessity of having a good security system has proven itself in our institution repeatedly. Last year, we upgraded our security camera system software, and the upgrade included one digital video recording unit. The hospital currently has 2 analog DVR units. They're both 8 years or older. I think that speaks for itself.
Even hard to say that word, isn't it? Analog.
Yeah.
Now in the
What is that?
in the digital age. Christine, if you call for a vote.
Sure. Director Stewart.
Aye.
Director Nicholson, I'm sorry.
Aye.
Director Danielson.
Aye.
Director Eben.
Thank you. That motion passes. Item B.
Item B, Mr. President, I move for adoption of resolution number 1147. This is a resolution to officially oppose Proposition 46, also known as a micro-reform measure, on our November 2014 statewide ballot. Proposition 46, if passed, would have an adverse effect on the ability of district residents to access care and greatly increase the operating costs of the district.
We have a motion. We have a second.
Second.
We have a motion and a second.
Mr. President, would you like me to read the resolution? I think it has a
I
number of interesting points
I think that'd
to be made.
I think that'd be appropriate. This is an unusual thing for the board to take a position on a proposition that's on the ballot, and I think it's worth reading that resolution. I think it's worth. We've spent one board meeting education system on this. I just remind the public that this is a very, very important issue.
Okay, resolution number 1147. Resolution of the Board of Directors of Washington Township Healthcare District to oppose Proposition 46 on the November 2014.
I think one thing that Bill said was tremendously important. Beyond trial attorneys giving themselves,
which owns and operates a general acute care hospital known as Washington Hospital and provides essential healthcare services to the population residing within the district's political boundaries, including the cities of Fremont, Newark, Union City, parts of South Hayward, and Sunol. And whereas, under existing law, the Medical Injury Compensation Reform Act, MICRA, patients are entitled to unlimited compensation for all economic damages, including compensation for lost wages and unlimited compensation for past and future medical costs. And whereas, according to the independent, nonpartisan Legislative Analyst's Office, Proposition 46 on the November 2014 statewide ballot would increase healthcare costs across all sectors by $9.9 billion annually. Let me repeat that. According to the independent, nonpartisan Legislative Analyst's Office, Proposition 46 on the November 2014 California statewide ballot would increase healthcare costs across all sectors by $9.9 billion annually. And whereas Proposition 46 would quadruple the cap on non-economic damages under the MICRA, and whereas the Legislative Analyst's Office warns that changes to MICRA could increase state and local government healthcare costs by hundreds of millions of dollars annually. Repeat, hundreds of millions of dollars annually. And whereas Proposition 46 also contains other provisions related to random drug testing of physicians and a prescription drug database that proponents have admitted are an attempt to gain voter support. And whereas both the district and the medical staff have existing drug testing programs for physicians. And whereas, according to the California Medical Association, Proposition 46 would reduce access and jeopardize patients' ability to see their trusted doctors and threaten the privacy of personal prescription drug information. I'll repeat that last point. Would threaten the privacy of personal prescription drug information. And whereas Proposition 46 is opposed by a diverse group of hundreds of other groups representing doctors, community health clinics, hospitals, nurses, labor unions, businesses and taxpayer groups, public safety groups, and community groups. And whereas the board held a public hearing at which members of the public were invited to address the board and voice their support or opposition to Proposition 46. And whereas the board is required to base its decision on what it determines to be in the best interest of the district residents. Now therefore, be it resolved that 1. Proposition 46, if passed, would have an adverse effect on the ability of district residents to access care and greatly increase the operating costs of the district. 2. The Washington Township Healthcare District is officially opposed to Proposition 46 on the November 2014 California statewide ballot. 3. No public funds are to be used in the campaign for or against Proposition 46. That's the resolution, Mr. President.
I appreciate you reading that. Are there any public comments before we move forward.
I think Dr. Brooks would like to comment.
Dr. Brooks, anxious to hear from Dr. Brooks.
Bill, this resolution is wonderful. You've said basically what I was going to say. I think it's just very interesting. The California Hospital Association has agreed to provide matching monies to fight Prop 46 for any medical staff that agrees to give money against Prop 46 on a 2-to-1 level. So if our medical staff, and they are currently considering, and it will come to the Medical Executive Committee, that our medical staff will be contributing to that and getting matching funds. For physicians, this is a double whammy. It's a nightmare and a catastrophe. It would take us back 35 years, and physicians would not be able to practice. They would have to leave the state. Obstetricians like myself would pay over $162,000 a year for medical malpractice coverage. Physicians like you, Dr. Nicholson, would probably have to pay 3 to 4 times what you're currently paying. It would be untenable. And physicians who work in community clinics, who work for family planning clinics, those clinics would not be able to afford physician coverage for malpractice. So I think this is wonderful, and I totally support the district taking this action.
Thank you, Dr. Brooks. I think it's important to mention that it's, as in a lot of propositions that appear on our ballots, it can be very misleading as to what you're voting on. This is called the Drug and Alcohol Testing of Doctors and Medical Negligence Lawsuits Initiative, which is misleading in and of itself. It's really an initiative presented by the consumer attorneys of California to allow lawsuits to increase exponentially against physicians and hospitals. It's a very dangerous, very, very, very deceptive proposition in my mind. I think we need to encourage the public to do all that they can to investigate and see what this initiative truly is. It's on the November ballot. It's a very, very important issue for the medical community of California. Are there any other comments that we need to consider?
I think one thing that Bill said was tremendously important. Beyond trial attorneys giving themselves a raise, they've also managed to create a database that will deprive average citizens of their right to privacy because of the information about prescriptions that will be contained there. This isn't confined to a few problem people. It is going to erode everybody's right to privacy. And I think Bill's remarks were tremendously important to repeat that part.
I think that I'd like to make just a remark on that. I think you could hear in Dr. Nicholson's voice his strong feelings on this issue as a practicing physician. His very livelihood is endangered. His ability to treat patients correctly is endangered. And this is an issue that needs to be addressed very carefully.
Mr. President, with all due respect, my livelihood doesn't matter. I think what really matters is the ability of patients who have serious illnesses to be able to access the health care facilities and services that they need. And I think that this resolution would substantially damage their ability to do that. And Nancy mentioned the prescription drug database. This database doesn't work well. And as Dr. Brooks told us at our last meeting, is that many times the ER physicians are trying to access the database to inquire as far as prescription history on a patient who presents in the emergency room for whom the physician has no prior experience. Those doctors are doing that voluntarily. This legislation, or this initiative, would require all physicians to access that database every time they write a prescription for a controlled substance. So I am concerned that not only would there be the potential breach of patient confidentiality and personal prescription drug information, but fundamentally the patient may not even be able to get the prescription that they need and that their physician determines is in their best interests. So that is only one aspect of how this will damage patients' access to care. I think there are many other aspects of this in that it will discourage new physicians coming to California. It will create an adverse environment in states which have these kind of initiatives in place. It's very hard to get new physicians to come to town. Texas changed their malpractice liability caps, and when they did that, a flood of new physicians came to serve the Texas patients. We don't want our physicians going to Texas. We want to keep them here. We want to keep them serving the needs of the residents of our district. I would be curious at this point to see what our medical staff, represented by Dr. Lunny, what the thoughts of the medical staff are and where the medical staff is in this process.
Thanks. I do have a couple thoughts, and to echo Director Stewart's description that a lot of times propositions are described one way, but what's hidden underneath is the real details of the proposition. And this is being presented to the public as a measure of patient safety, and not to discount the concerns regarding inappropriate prescription of pain medications or narcotics, or the problems of an impaired physician, that the solutions for that are described in this proposition are really of dubious or unproven benefit. When we implement things in our hospital to improve patient care, we use evidence-based means to do that. But the measures that they have in this proposition are not of any proven benefit to tackle those issues. And the real issue here is that it's going to increase the cost of health care on the order of, $10 billion to the state. And that's just going to increase the cost of health insurance for patients in general. And it's 2 steps forward and 1 step back, with the Affordable Care Act being implemented to presumably decrease the cost of health insurance and provide insurance to more patients. This just appears to be doing the opposite, and will also diminish the access of physicians for patients in general. So I think the medical staff is going to do its best to try to fight this proposition.
Thank you. Pat, you had a comment?
Oh, yes, I have a comment. As a longtime member of the health information management profession, I am appalled. I was trained, I have worked with confidentiality. That is one of the main jobs when you work in the medical record department, or now known as health information management. You are to protect the confidentiality of any medical information of that patient. I am appalled that this is even on the ballot, because that tears down everything that we have gained. I have watched the laws in multiple states, the Lanterman-Petrus Short Act, which relates to psychiatric information. And now we have this that is throwing all of that right out the door. There's no protection under HIPAA. These people's information is wide open to the public, and that is wrong. I'm appalled that it is being presented on the ballot in a very devious manner, and it frightens me that people will misunderstand this and think that this is for drug testing and alcohol testing, which is already going on. and that our patients' safety of their information will be disregarded, just for the sake of the trial lawyers. Thank you.
As she said, she had a comment. I think we're ready for a vote. Christine, if you would take the vote.
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Danielson.
Aye.
Director Epen. Thank you.
That motion passes. That completes our action items and our agendas for the open session tonight. We will now adjourn to a closed session. Thank you for your attendance tonight. We reconvene this meeting to an open session and announce that no action was taken during the closed session this evening. There being no further action items or agenda items tonight, this meeting is adjourned.